Good afternoon. Thank you for inviting me to participate in this webinar. I would like to congratulate the local organizing committee for putting together an excellent program. I have no conflict of interest to declare. Hysteroscopy in the outpatient setting is a natural progression of a procedure that we've all been performing in the main operating theater under general anesthetic for several years. To move this procedure to the outpatient setting is a no-brainer because there are obvious advantages. The nomenclature depends on where you practice. In the United Kingdom, it is generally referred to as outpatient hysteroscopy. In other parts of the world, it is referred to as office hysteroscopy or ambulatory hysteroscopy. Essentially, it involves the use of small caliber hysteroscopes to examine the uterine cavity without the need for formal theater settings and without general anesthetic. Obviously, this has been made possible because the instruments have been adopted, they're much smaller, so that you could use this without causing significant pain. However, pain remains an issue, and because these women are fully conscious, there is a degree of anxiety and obvious embarrassment when they walk into a room full of people. We therefore have had to change the way we work, adopt new techniques, and make the procedure much more comfortable so that patients will be able to tolerate this while fully awake. The obvious advantages in performing hysteroscopy in outpatient include rapid post-operative mobilization, so they come in and go home same time, even though we always advise that they come with an escort that will take them home. Recovery is obviously quicker, and they go back to work sooner rather than later. This all amounts to reduction in the loss of income as patients go back to work much quicker than if they had general anesthetic. To make this much more palatable for the patients, the setup has to be very spot on. Your treatment room should be private and patient-friendly. There should be a private changing room with ideally a toilet. There should be a comfortable recovery area and facilities for resuscitation in the occasional cases of vasovagal syncope. This is what your typical outpatient hysteroscopy setting looks like. Comfortable trolley, comfortable stirrups, a chair for the surgeon, your monitor, and if you're feeling rich, a second monitor here for the patient to follow what you are doing. The staffing is key. The BSGE has recommended at least 3 support nursing staff. And you'll see why. At least one of these members of staff should act as the woman's advocate to provide reassurance, explanation, and support. This would normally help to reduce anxiety and to divert the patient's attention, therefore minimizing pain and embarrassment. You may remember this big campaign against painful hysteroscopy in 2008, which attracted major headlines in the newspapers and actually led to a parliamentary debate on the floor of the House of Parliament that was brought forward by the MP for West Ham in London. This campaign led to the release of a statement by the British Society for Gynae Endoscopy that clearly stated that it is important that women are given the choice, that right from the onset, women should have the choice of having this procedure under general anesthetic or in outpatient. The BSG statement also clearly stated that the procedure should be terminated should the woman experience significant pain enough to request termination of the procedure. Also, the procedure should be terminated if the nurse who is advocating for the patient requests that the procedure should stop. The clinician can also use their own discretion to stop the procedure if they feel the patient is not coping. Various forms of pain relief have been tried. In my department, we use non-steroidal anti-inflammatory agents, including ibuprofen, which is administered 1 or 2 hours before the procedure itself. Non-steroidals have been found to be helpful for post-operative pain, but unfortunately, they don't control the pain during the procedure itself. Opiates, including tramadol, have also been found to lower pain scores, but also they don't tend to reduce the pain during the operation and have been generally discouraged because of adverse side effects. Your vocal anesthetic remains the most effective form of anesthesia. So therefore, if you want a successful outpatient hysteroscopy service, you've got to select your patients carefully. The patient who is not coping with a speculum in your clinic is not the one for outpatient hysteroscopy. You must provide adequate information pre-operatively that the patient will take home and read so they know what to expect when they come in for the procedure. Such patients who are well informed tend to cope better. The smaller the caliber of your hysteroscope, obviously, the less painful, and there's clear evidence. The non-touch vaginoscopic technique, where you insert the hysteroscope in the vagina, fill the vagina with saline, and gently navigate your way through the cervix without touching the cervix or holding the cervix to the vossolum, is associated with much less pain. Another good hysteroscopic principle is to use the bare minimum pressure to distend the cavity. Common sense would say that warming the saline would be much more comfortable, but unfortunately, whether the saline is warmed or not does not make a difference in terms of pain, how much pain is that the patient can feel. Your vocal anesthesia remains the most effective form of anesthetic. Now, whether you use a 0-degree hysteroscope or an angled hysteroscope doesn't seem to matter much. Dilating the cervix definitely is to be avoided, because if you're using a small caliber hysteroscope, there's usually no need to dilate. However, if you go perform a procedure in outpatient, including modulation of fibroids, then there's sometimes need to dilate the cervix. Should you need to do that, then it is advised that you apply local anesthetic to the anterior lip of the cervix before applying your teneculum. In terms of sedation, if you have to then use sedation, then it defeats the whole purpose of performing this procedure in outpatient. You can as well do it in your operating theaters. The use of sedation has not been found to be superior to local anesthetic or no anesthetic with regards to patient satisfaction and post-operative pain. So we don't use sedation. Now, what procedures could be performed in outpatient? Straightforward endometrial polypectomy, removal of small submucosal fibroids, endometrial ablation, removal of lost intrauterine devices, and transcervical sterilization. Two key areas where outpatient hysteroscopy has been found to be very useful are the postmenopausal bleed clinics and pre-IVF endometrial assessment. I'm going to elaborate on those two briefly. So obviously, small fibroids like this could easily be removed. Your transcervical sterilization and your coils, foreign bodies, including fetal bones, can be removed successfully in outpatient. The one area where outpatient hysteroscopy has been found to be extremely useful, with no doubt, is in the one-stop postmenopausal bleeding clinic, where women on HRT who are bleeding abnormally postmenopausal women who have a bleed are referred directly by the general practitioners into the one-stop clinic. They are seen by a doctor or a nurse practitioner who takes a history, examines his patients to exclude local bleeding from the cervix or the vagina, for that matter. These patients have a scan, as it's a useful skill to have, so you can not just take your history, examine, scan them at the same time to assess the endometrial lining. If the lining is thin, you can reassure and discharge your patient. If the lining is thick or there's a focal lesion, you hysteroscope at the same time and take a biopsy. You could find a simple looking polyp, which you can remove, or a polyp with some form of endometrial hyperplasia, which can easily be removed successfully with cold scissors or a bipolar device. You could find cancer, and outpatient hysteroscopy is quite useful for focal lesions, obviously. So there is no doubt that it provides an excellent service in terms of managing women with postmenopausal bleeding. With respect to cavity check during or pre-IVF, the role of outpatient hysteroscopy still remains slightly controversial. Lesions like this will hopefully be picked up by either a straightforward 2D ultrasound scan, saline infusion, sonography, or even HSG. Now, this looks like a septum. It is not. This is endometrial adhesions. And you've seen a few of these if you've done enough hysteroscopy. However, there are some subtle intrauterine lesions that your routine ultrasound scan might miss. It brings me to these two major papers, both published in 2016 and both published in the Lancet. The trophy study, which was carried out here in London by the group at Guy's and St. Thomas's Hospital, led by Mr. Tariq El-Tuki, they looked at 702 women who have had recurrent failed implantations, so 2 or more failed IVF cycles. These women were randomized into 2 groups, over 350 to have outpatient hysteroscopy, and the other 350 control did not have outpatient hysteroscopy prior to their next IVF treatment. The conclusion of these studies was that there was no significant difference in pregnancy, implantation, or miscarriage rate between the 2 groups. So if you've had recurrent failed implantation and you had a hysteroscopy, and then went on to do another IVF, or you didn't have a hysteroscopy, there's no difference. So they're suggesting that outpatient hysteroscopy does not help or make any difference in terms of IVF outcome in this group of women. A similar paper with slightly different group of patients was studied by the INSIGHT group, the Dutch study, where they also looked at about 750 women who were having their first IVF cycles with normal ultrasound scan features of the endometrium. 2 groups were identified, 373 hysteroscopy group, where all these women had hysteroscopy with treatment of lesions that were found. The second group did not have hysteroscopy, and these 2 groups of women went through IVF. Their conclusion was that routine hysteroscopy does not improve live birth rates in infertile women with a normal transvaginal ultrasound scan of the uterine cavity, who were going to have their first IVF treatment. So they suggested that women with normal transvaginal ultrasound scan should not be offered routine hysteroscopy. So in a nutshell, these 2 big studies are suggesting that hysteroscopy may not be useful before IVF, but I've always begged to differ because there are obvious weaknesses in these 2 studies. For a starter, if you look at the abnormalities that the investigators at the trophy study found, you would see that there are very few significant abnormalities that one would expect to affect IVF outcome. If you look at this study, which was published in 2009. Now, this was not a randomized control trial. This was a prospective observational study. This group looked at women who had failed IVF, and then they went back to hysteroscope these women and then looked at their ultrasound scan report to see whether they suspected intrauterine lesions. And you could see a lot more abnormality was discovered in this group of women in this particular study. But more importantly, look at the number of cases that were unsuspected on ultrasound scan. So essentially in the trophy study, they will consider all these women as having normal uterine cavities. But you could see that there were 49 polyps that were missed. Endometrial adhesions, they missed all of them on scan. They couldn't pick a single case of endometritis on ultrasound scan, and I'm not sure I'll be able to identify that. Endocervical adhesions, they missed all 22. So you could see, I think the population difference between these studies and the trophy study and INSIGHT study could explain why the trophy study and INSIGHT study reached their conclusion. Because this group went ahead to treat these women surgically and arrived at a completely different conclusion. Little wonder that when the same group that did the INSIGHT or the trophy study, the group that was led by Mr. L. Tucker, Guys, and St. Thomas's, then did a meta-analysis and systematic review in 2018, and they looked at a review of 3,179 women. Their conclusion was different. Their own meta-analysis showed that hysteroscopy in asymptomatic women prior to their first IVF cycle was found to be associated with improved chance of achieving a pregnancy and live birth when performed just before commencing IVF treatment. They concluded that the procedure was safe, but also suggested that larger studies are still required to confirm their findings. So, hysteroscopy before IVF or not, I think the jury is still out, and I think each case should be treated on its own merits. And in environments where there's potentially high risk of intrauterine pathologies, including septic termination of pregnancy, puerperal sepsis, high numbers of myomectomies with cavity breaches, I suspect that in those environments, possibly hysteroscopy may well be cost effective before IVF. Now, there's a need for further studies. And until then, I think each case should be treated on its own merit. Now, whether you subject a woman to hysteroscopy before IVF or not should be treated on a case-by-case basis. I will conclude by saying hysteroscopy in our patients is safe, is cost-effective, and well tolerated by most women. You have to select your patients carefully and provide adequate information before the procedure. You must have supportive staff who should act as a woman's advocate, and adopting the vaginoscopic technique with low saline pressure will help to reduce pain during the procedure. Hysteroscopy is well established as part of a one-stop post-menopausal bleeding clinic, and its role in IVF or women going through IVF remains to be established. I have a strong feeling that some group of women will benefit from having hysteroscopy prior to IVF. Thank you so much for your time, and I'll take questions at the end of the session. Thank you.